Dr. Patankar, Dr. Parag, and WIROC. So my talk is made easy by Kiran and Parag. So my talk is traumatic fracture dislocations of carpometacarpal joint excluding the thumb. So these are less than 1% of hand and wrist injuries. And most of the CMC dislocation occurs with other associated injuries. And they are mostly missed on X-rays of the wrist joint because and the hand due to the overlapping of the bones. So in brief about the anatomy, which is already discussed by Dr. Kiran. So at the carpometacarpal joints have volar carpometacarpal ligaments and the dorsal carpometacarpal ligaments. So dorsal are the strongest of the ligaments. So there are interosseous ligaments as well. And the motion of the CMC joints, it is maximum mobile at the 5th CMC, which is around 25 degrees. The 4th CMC mobility is around 15 degrees. And the 2nd and 3rd, which is already discussed by Patankar sir and Kiran, that they are more or less fixed. The 2nd and 3rd CMC joints have a plain type of joint structures, and the 4th, 5th have CMC joints has saddle type of joint structure. So these are the radiographs, what you will see. So as discussed earlier, that you have to look at this, this is the Shenton's line type of, you have to see the CMC clear space. So normally all the CMC joints in AP views will have this clear space. If the clear space is missing, there is some problem. Because most of the dislocations are missed here, and the 5th dislocation, which is the most commonest, is missed if you miss this clear space area. Another thing which is important is the metacarpal head tangential line. So this, the tangential, you draw a line along the head of 5th, 4th, and 3rd. So they form a tangent. This is excluding the index finger. So index finger doesn't include in this tangential line. This is mostly for subtle type of dislocations. In lateral view, so you take a lateral view and a 30-degree pronated view. So if you see another, if you draw another tangential line here, so all the metacarpals should not cross that tangential line in the lateral view. And 30-degree pronated view also shows dislocations. So this is an example of 5th CMC joint fracture dislocation. So in lateral view, you can see there is not much you can appreciate, but you have to compare it with the pronated view. In pronated view, you see that the line is broken, there is no clear space, and significant loss of this in AP view, sorry, in PA view, significant loss, the tangential line is broken. That means the metacarpal or 5th metacarpal head is sunken down. You can see that there is a dislocation here. This is an example of 5th CMC dislocation. Again, you see that the clear space is absent here, and there is a dislocation of the 5th CMC joint. So what are the deforming force? This is the 5th CMC is the most common type of fracture dislocation. So the deforming force is the pull of the extensor carpi ulnaris, which pulls the metacarpal head downwards and in extension, and also the shape of the hamate. The hamate bone is like a triangle, so it slopes down. So for such type of dislocations, what you will do? Close reduction can be a plan. Close reduction with ulnar gutter slap if it is stable, and you can wait and do a weekly X-rays. K-wire can be done if it is unstable, or open reduction and internal fixation might be required. So for this case, we did a close reduction and weekly X-rays, and it was stable. So this is another case in which there is a 2nd metacarpal base with 3rd subluxation. So in this, the idea is to stabilize the base of the 2nd metacarpal. So 2nd metacarpal was stabilized with a plate, and the 3rd CMC joint fell in place. So while plating, as shown by Parag already, if you plate on the radial side, you should take care of the cutaneous nerves. As you can see that the radial cutaneous nerve is crossing the plate and the incision site. And on the ulnar side, you should be careful about the ulnar cutaneous nerve. So this is another example. It's a high energy trauma with an impeding compartment syndrome. So most of the CMC joint joint fractures, if all the joints are involved, like in this case, they can be in compartment syndrome. So you have to recognize this. So this is third, fourth, fifth CMC joint fracture dislocation. All the dislocations, third, fourth, fifth, are dorsal. As you can see, there is a loss of clear space here. There is fracture of the base of the fourth and the fifth metacarpal bases also. And there is dorsal subluxation of the third, fourth, fifth. So in this, the treatment is give a traction, do a fasciotomy. So through the fasciotomy incisions only you can open, reduce, and fix it with K-wires as in this. So idea is to align the third metacarpal on the capitate. So that is the important thing. So the third metacarpal should be aligned on the capitate, as you can see here. So this is the post-op X-ray. Third metacarpal should be aligned on the capitate. And this is 5-year follow-up function. Second, third, fourth, fifth fracture dislocation. Now this is a very unusual type of injury with only one case report which I have found out by Dr. Kumar from Delhi. So it's a very high energy trauma. Similarly, you have to go in, do a fasciotomy. As you can see, the index metacarpal is dislocated volarly, and the rest of the metacarpals are dislocated dorsally here in the lateral view. So treatment is again do a fasciotomy, and through the fasciotomy incision do ORIF and reduction with traction and K-wire fixation. So again, the important thing is to align the third metacarpal on the capitate. This is follow-up after 3 years. So this is his post-op function. So fasciotomy is important in this case because, open reduction is also important because most important problem is flexion and extension. So this is a case which is provided to me by Dr. Hemant Patankar. So this is neglected second, third, fourth, fifth dislocation in which open reduction and K-wire fixation is done. 8-month follow-up and good function. So what is the take-home message? Fourth and fifth CMC fracture dislocation can be reduced in closed technique. Second and third CMC fracture dislocation is due to relatively high trauma. They can be associated with carpal injuries and have compartment syndrome. Do not hesitate to do a fasciotomy. Stable fixation with K-wire or plate can be performed. Beware of tendons and cutaneous nerve while during the exploration. And late injuries need reduction, extensor tenolysis, and aggressive therapy. Thank you.